Hi all, good evening. This is Alex from Intuitive. Today we will go through a session of a robotic low anterior resection with intracorporeal anastomosis, and this presentation will be done by Dr. Venkat P from Apollo Cancer Center, along with Dr. Priya. Dr. Venkat P is a senior consultant surgical oncologist in Apollo Cancer Center. In fact, he is the first surgeon who also who did the robotic breast surgery in India. There are many credentials um, to him basically. Along with him, Dr. Priya also would be there today, and both of them would be doing the presentation for the robotic low anterior section with intracorporeal anastomosis. Sir, good evening, sir. Over to you, sir.
Good evening, all. See, the agenda for today is we'll be discussing about robotic low anterior resection with intracorporeal anastomosis. As surgical oncologists, as gastro, and as general surgeons and colorectal surgeons, this is a very, very important procedure which we need to learn. Again, going the way forward, things are slowly moving from a lab towards robotic. So here we thought, I always believe that laparoscopy and robotic are not the same surgeries. They are two different surgeries, which we need to know. It's not that if you're going to be a very good lap surgeon, it's not just like that. You just cannot extrapolate something into a robotic surgery, because the principles, the port placements, and the instrumentation, the instrument handling, everything is completely different. Again, when we started the robotic journey, and when we started from open to lab to robotic, there were a lot of changes which we had to make. So those changes, and with a lot of, once you start doing it, there will be times when you get stuck, and there will be times when you need to change the way which you need to do and things like that. So initially, the surgeries which we started, when we look back, even we were like not very happy with it. Any surgeon will want to have a very perfect surgery done. That's the goal of any surgeon. And any surgeon will like to enjoy seeing this own surgery. The end of the surgery you feel like, yeah, you've done a very good job. So initially, what we used to do is, we used to let it be Priya and myself used to look at the videos of the entire surgery, what we have done. We used to always discuss how we can improve it and change it and things like that. So here we are at this part of junction of journey. We are in a place where we have learned newer things. Not a question of newer things. We have made mistakes. We have gone through difficult situations. And then we have come up with a step-by-step approach as how we do it. So the most important thing in robotic is, it's like, when you're going to do an open surgery, when you're going to do a laparoscopic surgery, you can skip steps. You can just, when you're doing an open surgery, you can skip a step and then come back and do the step again. But in robotic, I'll always say, take it step by step, and if you're going to go step 1, step 2, step 3, make sure that all the steps are being followed in a step orderly pattern, so that to ensure a very good outcome and a very good surgery. So this is what we do. So after this, what we have done is, we have just made a 20-point stepwise presentation, where following these steps, we sincerely, steadily follow these steps step by step, so that we get a very good surgery done. And again, it starts from the patient positioning. I always say the patient positioning is very, very important. Unlike laparoscopic surgery and open surgery, when you compare to laparoscopic surgeries, patient positioning is not as important as in robotic, because the challenge with robotic is that you just cannot change the patient position once you start the surgery, until you have got an integrated table. So here what we need to do is, the entire patient positioning should be done very, very well. So when you are starting off with the robotic surgery, the program, don't let your assistants or the theater boy do the positioning. It is you. From the time of after the induction, you need to be there in the operation theater to see how the patient is being positioned. See, it's very, very important that everything is sorted out, because we have seen multiple issues with positioning. Because once the robo is docked, you really cannot change the position again unless until there's an integrated table. So the most important thing is we always keep a low lithotomy. The low lithotomy, the patient is at the end of the table. Here, another thing is about sandbag. So initially we were using sandbags, and now we don't use a sandbag. And especially more so, we don't use a sandbag for a male patient. At least female patient, we don't mind using it, but for male patient, we don't do it. So initially, that was one of the learning things which we do. Some surgeons do, but we have found that not using a sandbag is more comfortable for us. Again, you need to always, I always say, have a good yellow fin or a blue fin where we can adjust the position of the legs. So again, this is very important during the procedure, because sometimes what happens, the arms, robotic arms do hit the legs. So we should be in a position where we need to make sure the yellow fin is adjusted so that the external clashes are not there with the patient leg or something like that. Again, there should be adequate padding. There should be adequate padding. I always say there should be adequate padding in the shoulders also. Say something, especially it becomes very important in obese patients, where you need to have a very good padding in the shoulders, and you need to have a very good padding in the calf to prevent some kind of a nerve compression. And again, in shoulders, say, to be very honest, we have also had, in spite of doing a very good padding, there was a very unusual complications. Here we also would like to discuss about one or two difficult complications which we have faced, where one patient, we are surprised that the patient had a clavicle fracture. So this was also there. So the padding, that will let you know, one simple thing will tell you how much importance the padding is. So have a good padding, because what happens, the entire weight of the patient's body goes on the shoulder. And especially what happens, we always give a tilt to the right side. So what happens, the entire pressure is more on the right shoulder. So especially in obese patients, padding is very, very important. Again, you need to make sure the legs are strapped, and again you put all the regular the SCDs and everything. You just need to put it on things, right? And always keep the arms neutral by the side. And adequate strapping is required for the chest also. So all this prevents the entire weight of the force going into the shoulder. Again, next thing is, once the patient is positioned, again we access and insufflate. That's a routine, the laparoscopic way which we do and things like that. And another thing is, we just place the camera ports and explore the abdomen as we assess for any surgery. We explore for ascites, we explore for mets, liver mets, and we explore for peritoneal disease and things like that. And then we place all the ports. Regarding the port placement, Dr. Priya will be talking about it. Next comes another important thing which I want to tell you is, again, a position of the bowel. Unlike, say, even laparoscopic bowel position is very important. Here, robotic, it becomes very, very important, because again, I say, in laparoscopy, you can change the angle of the table and things like that as we operate. But robotic, we cannot. See, spend time in positioning of the bowel. The bowel positioning is very, very important. See, you need to take your time. Don't be in a hurry to dock it and start the procedure. Spend time in bowel position. Even now, today, after so many surgeries, we spend a lot of time in bowel positioning, especially the small bowel. Make sure it's not like you just cannot pull the small bowel. The idea is the entire small bowel should be tried and packed in the just in the sub-hepatic area and things like that. It is difficult. You need to take some time. You need to flip the mesentery. You take some time and then position it. You pack it as much as possible. Then we also take a long gauze, which we pack it and things like that. So the crux of the matter is, positioning is very, very important. Patient positioning is very important. Again, don't forget about the positioning of the small bowel. And then comes the targeting and docking. So regarding all that, we can just discuss as we go and things like that. And then starts initiating the dissection. There's different types of initiating of a dissection, regarding which we'll discuss as we go forward and things like whether we start from pre-sacral or we go from just infra-MA, supra-MA and all that we do. Here, another most important thing is identification of and preservation of the hypogastric nerves. Again, we also do the dissections, then medial to lateral dissection, then IMA ligation, IMV ligation, and then splenic flexure mobilization, then lateral mobilization, TME dissection, divide the rectum, see again proximal division. So all this in a step-by-step manner we need to do. So once you do it, once you start, now it's like initially we were sometimes skipping steps. Now once this algorithm which we have made for ourselves, it has made the life of the surgery easy. For us it's very easy. And you say whenever someone looks at the surgery, it looks very presentable, it's nice, and you know that it's being done well, and the outcomes are good, and it's very comfortable to do this surgery. Next thing is coming to port placement. Again, Dr. Priya will be discussing about port placement. Regarding the instrumentation, we always use a 30-degree camera. I don't use a 0-degree. Very rarely I use a 0-degree, sometimes for the pelvis alone. I just change it, but usually I prefer a 30-degree. We make it up and down and things like that. Again, we use monopolar curved scissors. Another thing is, I always make sure I use a forced bipolar, because a difference between a forced bipolar is little on the maybe around 4,000, 5,000 expensive than the regular bipolar, but forced bipolar is quite comfortable. It's more finer than the regular bipolar. Again, if you see most of the videos, most of the people do use a pro grasp. And again, here we use only a tip-up grasper, because the advantage for us for a tip-up grasper is the advantage is that we can position, especially for small bowel positioning, I can use it. I can use it for splenic flexure mobilization, for giving a good traction on the bowel. All that is very, very useful. So I somehow prefer a tip-up grasper. So sometimes we make a conscious effort to take a pro grasp. So whenever, for instance, the number of patients are less, say post-radiation, in case I say a post-radiation, a male patient, say sometimes what happens, they do come delay. So sometimes they come a delay after 3 months or so. Male patient post radiation, sometimes the pre-op scan shows little bit stuck to the seminal vesicles and prostate and things. And those are the patients I make a conscious effort. So for instance, we need to do an APR or something. I make a conscious effort to use a ProGrasp, because ProGrasp is a beautiful instrument which helps in retraction of the prostate. So whenever there's prosthetic, whenever I know that this particular patient, male patient, especially if there's going to be a good difficult prosthetic dissection, I definitely use a ProGrasp. In that case, I know the entire challenge of the surgery is going to be the prostate and seminal vesicle area. So the ProGrasp is an excellent instrument to retract the prostate. So definitely this thing, tip-up grasper cannot this thing for that. Again, for all the patients, we also use a Surefirm stapler. And Surefirm stapler, it's extremely good for using a Surefirm stapler. And next thing is, whenever we do intracorporeal, see, I as a robotic surgeon, I like to use all the gadgets of the Intuitive because it's more comfortable. It has been designed in such a way for robotic and things like that. I don't preferably do a hybrid surgery. It's not like I let my assistant do from outside. I don't use a harmonic, or I don't use any kind of vessel sealer and things like that. I like to have the entire control. I also use, whenever I'm going in, most of the times we use only an intracorporeal. I personally prefer using only a vessel sealer. So that makes a lot of difference. And of course, there's another small instrument which I have not mentioned here is robotic clip applicator. So trust me, the robotic clip applicator is a fantastic instrument, and it helps you compare. That's what I'm just making it very clear. I don't do a hybrid procedure. I don't do a procedure where I use from the assistant port. I don't keep putting a clip side from the assistant port. I don't try putting a vessel seal, any kind of sealing device. I just like to have the entire control. So another thing is, by using the clip applicator, what happens is the entire thing, whenever you put a clip, the clip should be perpendicular. It should be perpendicular to the vessel what you're putting. So that makes a lot of difference when you put a clip applicator, where so whenever you see when you're going to put via assistant port a clip, that will never be a perpendicular clip. That will be around 60 degrees, 70 degrees, and things like that. To have a good seal, it's around 90 degrees perpendicular should be put. That gives a thing. So these are things which we do. Now, Dr. Priya will be talking about the port placement. Over to Dr. Priya.
A very good evening, everyone. So I'll be discussing about the ports first, which is our next step in the surgery. So we take a line from the anterior superior iliac spine to the tip of the costal margin, and 2 to 4 centimeter above, depending on the body habitus, we take a straight line. So port positioning for the XI Da Vinci is very simple. The ports are mostly taken in a straight line, and the camera is just above the umbilicus, two working ports on either side of the camera, and in the right iliac fossa, we have the retraction arm. We use two assistant ports sometimes, the 12 mm port and the 5 mm port.
And so another thing is I just like to add in the port. So the other thing which I want to do in the port placement is, say again here, just a small quick thing. Whenever you're doing a port placement, go with the mindset that it will little bit vary from patient to patient, and especially it's very difficult when you're dealing with a small abdomen. So that's very important point. Yeah, Priya will take it forward.
So it is important to understand the anatomy of the procedure. So just to start with the procedure, we would like to discuss a few points, relevant anatomical points for the procedure. The most important is to understand the facial planes in low anterior resection. So here the endopelvic fascia anatomy is very important. It forms two layers, which is the visceral layer of endopelvic fascia and the parietal layer. Then we have the denonvillous fascia and the valdeus fascia posteriorly, and the denonvillar fascia is anteriorly. The dissection should be carried out along these planes. It is important to understand that we should identify the planes. We should not create our own planes, and we should go from the known plane to the unknown plane while dissecting. Because here, even if we go posterior to the parietal layer, we will find the same areolar tissue. So it is very easy to get confused, and correct identification of the planes is very important. Here you can see here the two layers, the rectal fascia propria, which is the blue line which you can see here. This is the visceral layer of the pelvic fascia, and this is the parietal layer of the pelvic fascia, if you can see my cursor, and the dissection should happen here. This is the rectogenital fascia, the denonvillous fascia, which is the anterior boundary for dissection, and the valdeus fascia, which is the rectosacral fascia, which we open to enter into the lower pelvis. For dissection, there are various approaches. You can start supra-IMA, infra-IMA, infra-IMV, medial to lateral or lateral to medial. For our procedure, in most of the times, we do a infra-IMA, medial to lateral approach. So the nerve anatomy, we should know the anatomy clearly, because autonomic nerve preservation is the most important aspect of this surgery. So there are three important nerves involved: the superior hypogastric plexus. It is a sympathetic plexus which is formed by the contributions from the pre-aortic plexus and the inferior mesenteric plexus. It is located anterior to L5, and the sympathetic trunks are from T10 to L3. The inferior hypogastric plexus is a mixed nerve. It receives parasympathetic fibers from S2 to S5, and together with the hypogastric nerves, it forms the inferior hypogastric plexus. It is present like a rhomboid structure on the pelvic side wall. Then the pelvic splanchnic nerves. These are the purely parasympathetic nerves located in the lower rectum. They enter the pelvis through the sacral foramina and lie posterior to the parietal fascia. In the lower rectum, they pierce the parietal fascia and run to the rectum by the so-called lateral ligaments. So here you can see the superior hypogastric plexus, the right nerve and the left nerve. The right nerve and the left nerve receive contributions from the pelvic splanchnic nerve, which is the parasympathetic fibers, and it forms the mixed nerve fibers and supply the urogenital system. Again, the superior hypogastric plexus goes right, left, and here the pelvic splanchnic nerves give contribution. The inferior hypogastric plexus is formed, and it contributes to the neurovascular bundle of Walsh. The similar anatomy here. So it is also important to identify the morphology of the superior hypogastric plexus, so that it helps us to identify. The nerve morphology can be in the form of a mesh, as seen here. It is like a mesh here, or it can be a single nerve. So it can be present as a single nerve, or it can be like multiple fibers, like how it is seen here. So the orientation of the plexus is important. The hypogastric plexus bifurcates below the aortic bifurcation in all the patients, and the IVC bifurcation in about 92% of the patient. It lies about 2 centimeters medial to the both ureters. On the left side, it is close to the left common iliac vein, and on the right side, it is very close to the right internal iliac artery. So what are the key zones at risk during the surgery? The most important one is the origin of the IMA. Here, the pre-aortic plexus or the inferior mesenteric plexus or the left trunk of the superior hypogastric plexus can be injured. In posterior dissection of the rectum, the hypogastric nerves can be injured if we don't enter the correct plane. Here we would like to say that the hypogastric plexus here is dividing in a wishbone-like pattern. During the lateral rectum dissection, in the high lateral rectum dissection, the hypogastric nerves can get injured, and in the low lateral dissection, the inferior hypogastric plexus here can get injured if we don't enter the correct plane. Anterior rectal dissection is very important to preserve the neurovascular bundle of Walsh. Here, the neurovascular bundle lies anterior to the denonvillous fascia. And if the tumor is not anterior, in the posterior and the lateral tumors, we do not need to resect the denonvillous fascia, and it helps us preservation of the nerves. So sympathetic superior hypogastric plexus can get injured at the IMA dissection. Hypogastric nerves in the posterior dissection. The splanchnic nerves, pelvic splanchnic nerves rarely get injured in this dissection. Mostly when we are doing a radical lymph node dissection, then they can get injured. The inferior hypogastric plexus in the lateral dissection and the neurovascular bundle of Walsh during the anterior dissection. Medial to lateral dissection is between the Toll's fascia and the mesocolic fascia. It is important to identify the left ureter and the gonadal vessels. The squiggly vessels that we see in medial to lateral dissection, we should know that should lie on the retroperitoneal side. So inferior mesenteric artery, it lies 3 to 4 centimeter above the aortic bifurcation. The left colic artery is the first branch, and there are various IMA anatomy variations that we should be aware. It was given by many authors, by Latarche, by Predescu, and Zebrowski, Wangs, etc. But what we commonly follow is the Yada's classification. Here in type 1, the left colic artery arises independently. Here, the left colic artery and the sigmoid artery come from a co-trunk. So here, if we take the left colic artery, here the length may be a problem. And in type 3, the left colic artery, the sigmoid artery, and the superior rectal, they all come from the same point. Here, if we take a high ligation and there is the agenesis of the arc of Riolan, we may have some vascular problems. So it is important to identify these variations on the pre-op imaging. So IMA ligation is a very important step. High versus low ligation. There is various studies have been done. There are advantages and disadvantages to both the approach. With high ligation, we have adequate lymph node clearance and tension-free anastomosis. With low ligation, the advantages of good vascularity and adequate nerve preservations exist. So it is also important that we know the boundaries of the node 253 dissection, the nerve plane for IMP preservation, and intra-seed dissection of the IMA. So what is the nerve plane? So this is the pre-aortic plexus nerve plane which lies beneath the IMA origin from the aorta. So the node 253 station involves nodes which are present above the nerve sheath as well as below. But oncologically, the nerve plexus lies outside the mesorectum. So the nodes which are present extra to the nerve plane are not important and need not be dissected. So only the nodes which lie in the nerve plane should be dissected. This also helps us to prevent damage to the superior hypogastric plexus. So there are two the bilateral trunks of the IMP. The right side lies away, but the left trunk of the IMP lies very close to the IMA, and it is almost adherent to the IMA sheath. So when we are lifting the IMA for ligation, these nerves tend to get lifted up like a tent. So it is important that we open the sheath of the IMA and make the sheath fall down so as to preserve these nerves. As you can see here, this is the plane. So when we dissect, we will be opening the sheath of the IMA to prevent injury to the left trunk of the inferior mesenteric plexus. What are the key tips that we should follow to prevent injury to the nerve plexus? Ligation of the IMA should be done 2 cm from its aortic origin to prevent damage to the superior hypogastric plexus. Avoid mass clamping of the IMA. Do not mass clamp the IMA. Open the artery sheath and prevent injury to the inferior mesenteric plexus. Preserve the Girota's fascia because it contains the pre-aortic fibers. When we are doing the transition from the mesosigmoid to mesorectum also, we can have injury to the hypogastric plexus. So here we have to follow the plane which is immediately posterior to the superior rectal artery. That is a very good landmark. Splenic flexure mobilization is also a very important step of the procedure, and it can be done when it is required, but we are very flexible. Most of the times we follow the splenic flexure mobilization. Splenic flexure mobilization has multiple approaches. It can be either started infracolic, supracolic, or laterally. We follow mostly the infracolic approach, which is the bottom to up approach. Dissection starts under the IMV. Pancreas is identified and entry into the lesser sac done. The colon is separated from the tail of the pancreas and the omentum is released from the transverse colon. Here we can see during the dissection, during the splenic flexure mobilization, here we dissect the pancreatico-colic ligament, the splenocolic ligament, and the phreniocolic ligament and the gastrocolic ligament. Here you can see the dissection from the ventral part of the pancreas. Also, when we are doing the splenic flexure mobilization, we have to understand the role of the marginal artery of Drummond, the arc of Rayolin, which is the anastomosis between the ascending branch of left colic artery and the left branch of middle colic artery, and the Moskowitz artery, which is an anastomosis between the ascending branch of left colic artery and the base of the middle colic artery. So the TME dissection, again now after we finish the splenic flexure mobilization, we move towards the TME dissection. It is very important to identify the TME plane. The TME plane, the mesorectal fascia is thickest posteriorly, anteriorly it is thin, and it is absent 2 cm above the levator ani. During the dissection, we should identify the silver shining areolar tissue, which is the angel's fiber between the VLPF and the PLPF. So the rectal dissection, it is important. We first do the posterior dissection, and we have to preserve the pre-hypogastric nerve fascia and the Valder's fascia. Up to the Valder's fascia, we do the posterior dissection. Then we do the anterior dissection. Rectovaginal, rectovesical peritoneum is incised, and the plane of dissection is just posterior to the denon-Valder's fascia, and then the lateral dissection, and the nervi aerogentis is identified and preserved. So Kinugasa showed us the importance of preservation of the pre-hypogastric nerve plexus fascia. So over the hypogastric plexus, we have a fascia that has to be preserved so that there is optimal function of the nerves post to the surgery. Here you can see here the hypogastric plexus, and here the mesorectum, and the hypogastric plexus is preserved and the mesorectum is pushed anteriorly. Here the lateral view, the nervi aerogentis from the mesorectum, and here anteriorly this is the denon-Valder's fascia, and the dissection will be done in this way. Distal transection, after we have done the complete TME dissection and we have identified where is the margin to be transected, we prepare the rectum for distal transection. In ultra low anterior dissection, there is minimum mesorectum that is left, so it is easier to fire the stapler there. But when we are doing a partial TME, dissection of the mesorectum is required. Here we should be careful to avoid the apple peel effect, and we usually use the shear form staplers. In position, we fire from 12 to 6 position. Usually 2 or 3 staplers are required. After the distal transection only, you should move towards the proximal transection. We can use the vessel sealer or any energy device. Anvil can be placed intracorporeally or extracorporeally through a phalansteal incision. After the proximal dissection, we check the perfusion with the help of ICG, then perform the anastomosis, which can be a end-to-end or side-to-end, intracorporeally or extracorporeally, or hands to end. Then we do the diversion ileostomy. So now we will go for today's patient. Today's patient, she is a 50-year-old lady who presented with complaints of constipation and perrectal bleeding for 6 months. On evaluation, there was a circumferential ulcerated mass at the rectum, 6 centimeter away from the anal verge, and it was biopsy proven to be moderately differentiated adenocarcinoma. The CA was 18.6. The PET-CT showed FDG with irregular malignant wall thickening involving the mid part of the rectum, perirectal nodes, no metastatic disease. In view of EMVI, she was started with the TNT approach. She received 6 cycles of NFET with FOLFIRINOX, followed by long course radiation, 50.4 gray in 28 fractions. After counseling, she was prepared for surgery. These are the images. We can see distance from the anal verge, 4.6 centimeter on the MRI. This is post-chemo. She also had a lap hysterectomy done 5 years back. And here we can see the MRF was clear, 2 mm after post-chemo radiation. EMVI was still persistent after the chemo radiation. Apollo Cancer Center, Chennai. So today's case is a 50-year-old lady.
Can we proceed with we'll just proceed with the video now. So I think we have just got a gist of Dr. Priya's presented a gist of the case and how we go about an outline has been given. Now we'll go to the video. Yeah.
Diagnosed with low rectum, moderately differentiated adenocarcinoma. She underwent 6 cycles of FOLFIRINOX followed by long course of chemoradiation, which she finished on 20th of February. So we went with TNT approach. So relevant past history, we will be discussing the images. The relevant past history, what she has is she underwent a lap hysterectomy in 2017. Other than that, there are no other abdominal surgeries. As you can see here, so the body habitus of the patient also, she is a high BMI individual of 41 and undergone a lap hysterectomy in 2017. Here I would also like to introduce our team. He is Dr. Bhanu Sagar, who is a DNB resident surgical oncology, and Dr. Mahesh, he is a senior registrar with us, and Sister Ovia, who is a senior scrub for robotic cases. We will access the abdomen through the Viris needle. After creating Nemo, I will explain how the ports are placed. That gas, no? So for port placement, the costal margin is marked, the anterior superior iliac spine is marked, and we draw a line through the umbilicus. The camera port, we take it 2 centimeters above the umbilicus. Because it is a low anterior resection, we will have equal dissection in the pelvis and the mobilization of the splenic flexure. So here we take the camera port just above the umbilicus. This is our first port.
So now I think we're just putting the 2 ports is over. This is the 3rd port which we are putting. Let's check it out. The 3rd port. So here we are just putting this I think this is this is a 5 mm port. So we have put all ports, and then we are using a air seal also. You need to make sure all the robotic ports, it's there somewhere in the all the robotic ports. It should be in the black area. It's called a remote sensor. It's very, very important. This prevents it then from having a lot of trauma in the during the surgery. This is the difference between how post laparoscopy, there is a lot of pain, there's a lot of ecchymosis and a little bit of bleeding in that areas. And because it works on the remote sensor, because if you keep it exactly in the anterior abdominal wall, then the pain is less. So now we are discussing about the patient positioning, and now all the ports are over. Now we are just going before docking. These are the instruments which we use: a tip up, a scissors, a bipolar, and a 30-degree camera, and all this is being used. Say, as I mentioned earlier, it varies from patient to patient. Most of the time, it's going to be a tip up. Next thing is, sometimes for a very difficult case, which is a male patient, narrow pelvis, the prostate seems to be stuck, then I use a prograsp. So again, here you can see there were some. This is just an initial assessment. Now we are targeting. Once the targeting is over, and then we just put the instrument. This is the monopolar scissors going in. This is the tip up. So initially, say this particular patient was quite an obese patient. So one tip and trick is that, say what happens, because these obese patients have got a big omentum. So what happens whenever there's a big omentum, see, we will not be able to place the bowel properly, small bowel properly. You can just see on the entire small bowel is there more on the right side. You being on the left side. So what happens, we do little bit of release of the omentum so that we can push the omentum cranially. Once you push the omentum cranially, then you will be able to position the bowel better. So sometimes in obese patients, it's very, very important to little bit make sure that omentum doesn't fall and it needs to be flipped upwards. So this is what we are doing. This is not a splenic flexure mobilization what we are doing. This is just making sure the little bit of attachments of the omentum is released and we are able to flip the omentum. So because once the omentum is flipped, there's a lot of space. So this off late for recently, this particular procedure which we have been doing off late for quite an obese patient with a high BMI, this helps us for better. This procedure is predominantly only for placing the small bowel. So, so here you can see that the omentum is being released, and then it's going to be flipped up cranially. This is not a must for all thin patients. We don't do this. Only when you see that, when you feel it's very obese patient, the omentum is too big, very fatty omentum, then we tend to do this. This is another important step which I will definitely recommend when you have got an obese patient. So this step we are doing only for small bowel positioning. This is not a part of the procedure. Even if you see our workflow, we have not mentioned about this. This particular patient, we had to do it, so we are just showing you this.
So before we start the procedure, as you saw, we put the position in extreme head low and with left up. After doing that, we laparoscopically position the small bowel in the right upper quadrant. But because of this patient, the patient was obese, the bulky omentum, the proper placement was not possible. Hence, we are now releasing the omentum. The omentum kept falling and the bowel also kept falling. So here we can see with the Da Vinci Xi, a multi-quadrant surgery is so beautifully possible. We have docked for the left side, but we have almost really reached up to the right side for dissection.
So now, after that, we are able to position the small bowel After that, the momentum was pushed up, so there was a lot of space. Then we can position a small bulb. So this is not, because this patient is quite obese. So again, you will never get a patient where the positioning of the small bulb becomes very perfect. It's usually possible in thin patients. A little bit obese patient always is a challenge. Remember that. Don't think that all the surgeons will be able to position it perfectly, because positioning is a little difficult in all obese patients. Again, here we are going with a pre-sacral approach. See, in spite of mobilizing, you can just see the small bowels are coming in because of the obesity. So again, we just go pre-sacrally, we just make a nick, we just make an incision, get into that avascular plane, then try to connect, then make connect it with the infra-IMA. Again, we make an incision infra-IMA, then we just connect it. We are connecting the pre-sacral and the infra-IMA. You just see the clear-cut avascular plane. So this is the advantage of using a progress. Sorry, for a tip-up. The tip-up will clearly, you can just hold the bowel well. So the difference between a tip-up and a progress is that progress we can only retract. Progress is a very strong instrument. You will not be able to hold the bowel well. So progress is a very good retractor. Tip-up is not a very good retractor. That's why I said for prostate, I use a progress tip-up. Otherwise, for prostate, I use a progress. For all the other things, I use a tip-up. Tip-up, you can hold the bowel well. You can hold the artery, you can hold the vein. And then retraction is up to an extent decent because it's quite a broad instrument. The instrument tip is also long. Here you can see that I'm just holding the vessel. IMA, I'm able to hold it. So I'm just holding the IMA. So this you can't do it with with the tip-up. With the progress, with the progress. So again, here we are going we are just seeing the planes, we are just going the infra IMA, we are just going. This is very, very important step. So this is where, say, the left side nerve is in close proximity with the IMA. The right side nerve is away from the IMA. We have seen it in the discussion. So we need to be very careful with that. So we need to make sure that we preserve the nerve at every level. This is one of the areas where the nerve can get damaged. So again, because of the obesity, it's always better we just release. You can just see the nerve lower down. You can just see the nerve lower down. And again, say what happens, sometimes the traction will not be adequate, so we need to release some more. Sometimes it will be an inferior release, sometimes it might be a superior release. We need to release it some more. And always I tell you, like, say, when you are doing a robotic, you should have a very good assistant who understands your thought process. Another important thing is in robotic, I always insist that communication is very, very important. The communication is extremely important between the surgeon and the assistant. So it's extremely important, unlike open or laparoscopy, because we are sitting at different places. So the communication is extremely important. And it takes time to build a good team who understands what the primary surgeon wants. I understand what the assistant is doing and things like that. It takes a time.
So here we are doing the infra-IMA dissection, medial to lateral. So you can see very well how the nerve fibers are being preserved. The superior hypogastric plexus. So it is not just important to preserve the nerve, you should also preserve the fascia over the nerve. So that is the pre-hypogastric nerve fascia. So the fascia over the nerve also should be preserved.
So here you can see that the tip-up is also being used as a retractor. So tip-up can be, you can hold the bowel, you can hold the vessel, and you can even retract it. So that's one advantage. So all colonic patients, I just take a tip-up. Again, you can just see the nerve being dissected. And now we are coming close to the ureter. Yeah, you can see the peristalsis. So once the nerve is, I can just show you the nerve is over, then we go to the ureter. So this completely everything is an avascular plane. So the most important is to identify the structures. From medial to lateral, it's the first comes the nerve, then comes the ureter, then comes the gonadal. So take time and just identify each and every structure, because so whenever your surgery is bloodless, you know that you are on the very right plane. So whenever, most important, if you think that there's some oozing, the next thing is you need to think, there you can see the gonadal also. So now you're seeing all three structures, artery, the nerve, ureter, and the gonadal.
All the three structures have been preserved very well with the fascia over them, which is also very important. So now you can see here the superior hypogastric plexus on the left side, which is being pushed down.
This is the medial to lateral dissection. So you need to go from medial to lateral and take your time, do it, reposition the tip up on and off. And now here we are just trying to delineate the IMA. So once you cut the IMA, you'll have still more space. This is called the intra-sheath dissection of the IMA. This is the intra-sheath. You can just see the sheath being cut. So this becomes very important, especially, for the left side where it's very, very close. This is the intra-sheath dissection. Again, you retract it. Again, you just see the intra-sheath dissection, medial to lateral. Whenever we go medial to lateral, we go completely lateral until we see the psoas. This is the intra-sheath dissection. You can just see that the sheath over the IMA is being taken off. Now you can just the IMA you have got. So you need to be very meticulous in this. You need to make sure that the nerves are well being taken care of. And always another tip is, whenever we are doing this, you can reduce the current. When you are going to, usually we keep it around 3. Sometimes I say whenever you're going to the vessel, you can just make it even 2. And always another important tip is, whenever you're going near the vessel, use just one limb of the scissors. Some people are use a hook. So most of the times the hook, say I'm a person who uses only a scissors, I don't use a hook. The scissors has got a lot of other advantages of cutting and using. So I've been always used to using a scissors. You can see the IMA is being delineated very clearly. Again, here there are two types of dissection, 2 types of ligation. One is a high ligation, one is a low ligation. High ligation is going until the just close to the aortic, by the origin, at least 1 or 2 centimeters above the origin you ligate. This is what we always do, is a high ligation. We always do a high ligation. Another important thing is, once you make a space with the help of a bipolar, you just open it up well, because you open it up craniocaudally, then mediolaterally. Because very important is for you to apply the clip, and this is a robotic clip applicator. For you to apply the clip, it's very, very important. So applying the clip is one, and then removing the clip applicator safely is another. Look at the perpendicular way in which the clip is being applied. So we put 2 clips down and 1 clip above. This is the, say again, this is the note 253, which we are removing it. We just want to delineate more. Little obese lady. So there is the thin patients, even more, it will be easy to have a good look at the anatomy. Again, say whenever you're doing a presentation, say whenever you're doing you will not get the ideal case, but you need to be ready for it. Always it's again the upper clip. So now we know it's totally safe, and now you can cut it. So just see, once you cut the IMA, you just see again the tent completely opens up. So you're even more in a better position because you can just see. Yeah, you can just see it. And this is again the medial to lateral dissection. That fascia is the Gerota's fascia. I'm just keeping the Gerota's fascia. I'm just pulling down, cutting the Gerota's fascia. One area, a small breach is there, but cutting the Gerota's fascia. This is the IMV. Again, we just lift the IMV. We just retract the IMV. See, because of the obesity, the bowel keeps falling. So never think that there will be a perfect bowel. You need to try and achieve for a perfect bowel positioning, but it's not possible. That you always remember. So sometimes when you see a YouTube video, they'll show the perfect videos. It's not like our intention is not to show the perfect video. Our intention is to show the practical video, which day to day, which you come across and things like that. This is the IMB. Here you can see it's the Gerota's medial to lateral dissection. You just need to try and see the pancreas. So IMB also we take it till the root. So this gives us the extra length. This gives us the extra length whenever we are doing an ultra low. You can see that Gerota's fully not breached. And it's completely a slope. It's a bloodless field. So you need to do it very patiently. You need to do it step by step, never jump steps. So we are just doing the exact step what we have mentioned in the algorithm. You just keep doing medial to lateral. You take your time. It's a completely a bloodless surgery. Usually it will be. Again, you need to go completely down medial to lateral. You need to go until you try and look at the spleen. You need to look at the pancreas. In doing this dissection, you need to look at the pancreas and you need to look at the spleen. We always keep a gauze at the end. Here, the most important thing is you need to be careful. When you're retracting, you can retract the artery quite firmly, but you need to, when you're retracting the vein, you need to be a little careful. You need to make sure, because these are all powerful instruments. When you have an internal collision, when your movement should be small, because sometimes what happens, because of internal collision, the vein can even snap. Be very careful about it. And we are just going medial to lateral. So one of the advantage of, see, if you notice, we have not ligated the IMA. Before that, we are trying to go as much as medial to lateral. Because once you ligate the IMA, can you just see IMV, sorry, once you can just see the bowel just above it. Once you ligate it, you will just know that the entire thing just starts falling off. So as much as dissection, I do it before we ligate the IMV. So because IMV acts as a tent, it prevents the bowel from falling off. So once you ligate it, all the bowels will start falling. Then to do a medial to lateral becomes quite difficult. So just take your time and you just try. Your aim should be to try and do as much as medial to lateral, as much. So going until the spleen, because always we tend to think that, okay, we'll just try to do it laterally. Because we are all so used to doing it in open surgery laterally, but trust me, this is a far comfortable procedure to do it medial to lateral. So now we are going down and ligating the IMV near the pancreas. See here, the obese patient, so we are not able to see it properly, but usually just above the pancreas, we just ligate it. Again, another important thing is, say, unlike laparoscopic clip applicator, you need to understand that a robotic clip applicator, laparoscopic clip applicator, you can put it as a partial. Partially, the vessel can be put and then you can put another clip. But a robotic clip applicator, you need to put the entire clip. Say you need to dissect well, so you need to, it will not, if you go try to put it partially, it will not hold. So we have just taken the IMV also. Next, again, we are going still medial to lateral. We are dissecting with the help of a tip up. We are going medial to lateral. You can just see the Gerota's fascia. The fascia is being well preserved. And now you will get the pancreas, the lower border of the pancreas. You can just see that's the lower border of the pancreas. You can just see the lower border of the pancreas. Again, you just push the pancreas down. So your idea is to be, from here you should try and see the spleen. From here you should try and see the stomach. Only then the complete medial to lateral dissection is over. This is also a part of the medial to lateral, and it also partial, it helps in splenic flexure mobilization also. It makes, once you do this medial to lateral completely, as much as possible, you can see the pancreas, as much as pancreas, this also is a part of where you get the ligaments, part of splenic flexure mobilization is done from here itself, the inferior part. You can see the pancreas very clearly.
So this is the part of the intracorporeal dissection for splenic flexure mobilization. As you can see here, the dissection is proceeding over the ventral surface of the pancreas. After this, we are going to cut the pancreatico-colic ligament and enter the lesser sac. And as sir explained, the complete medial to lateral mobilization has been done. And once you finish the dissection medial to lateral, we place a gauze there so that when we go laterally, we are able to see it and we know that we have reached. So here we have entered the lesser sac and the complete dissection of the colon from the pancreas is done. After this, we proceed with the lateral dissection.
Yeah. So this is the easiest part of the surgery. Usually what happens, we always, when we start doing this, this is the first step which any senior surgeon will give it to the junior when they start doing the robotic, because it's quite a safe procedure, and you've got a lot of movements from caudal to cranial, so it's kind of nice to do. There's no vital structures there. Already all the dissection has been done, and it's very comfortable. It's a very pleasurable step, and you just need to unzip it.
So most of the dissection has been done from the medial aspect, so it's easier. Now you have to just cut this fascia for the complete mobilization of the left colon and the splenic flexure. So you can see we are using 3 instruments. For retraction, 1 instrument, that is the macro traction, and the force bipolar is giving the micro traction, and the scissors are used to create the planes.
So again, this is the advantage of using a prograsp, because prograsp can comfortably, for the tip up, because it can comfortably hold the bowel, large bowel. This is the medial to lateral, lateral to medial, which we are just already, the most of the dissection has been done medially. This is the lateral to medial. Again, another important thing is we always use an air seal. Especially, it's very comfortable when you're doing a left side colon, especially for post RT. So if you see this, the number of camera changes will be very less, and the pressure is maintained, the suction is maintained, and that makes it even more comfortable to use to do the surgeries. It's again the lateral to medial. Again, this is part of the splenic flexure mobilization. If you notice there was a small part which we did at the starting of the surgery, where taking out of the omentum and pushing it little cranially. Again, this is another important step. This is a step where sometimes what happens, the instruments don't reach and the instrument starts clashing. Here the thing is, we have targeted towards the IMA. Then what happens, it starts clashing. Sometimes there'll be external clash and things like that. So there is a thing where what we do is we just the entire boom we turn towards the splenic flexure. The entire boom we turn towards the splenic flexure, so the clashing becomes less.
Here we can see the gauze that we have kept from the medial side, and the phrenicocholic and splenocholic ligament are being incised here for a complete splenic flexure mobilization. So most of the times we do the splenic flexure mobilization in the single docking. Because of XI, we don't need to change the docking, but you can always change the orientation of the instruments more towards the left upper quadrant. After the complete splenic flexure mobilization, we are moving towards the pelvic dissection.
So another thing is splenic flexure mobilization. We as a routinely we do it for all patients. Routinely we do it for whether it's high or low, we do it because I will recommend all of you to do it. The reason being that once you start doing a splenic flexure mobilization, whenever it's difficult cases, it makes it life easy. So this is what we started. We started for doing for all the patients. Now, say after we have a little bit more, mastered it and kind of used to it. Now, sometimes selectively we avoid it and things like that. But most of the patients we do it because we want to have a nice floppy bowel at the pelvis. And this patient already had a hysterectomy. See, the most important thing is what happens whenever there's a uterus. Again, if the patient has not had a hysterectomy, we always tend to hitch the uterus with an external stitch because otherwise the uterus, the ovaries keep falling. So we just tend to hitch it. You can just see the left side nerve there. And then we go to the avascular plane. Here the most important is, again, as Dr. Priya was telling, you need to give a macro and a micro traction. This, the micro traction is being given by the bipolar. If you see that, if you notice it, it's always a dynamic traction. It just keeps pushing. You just should not keep it static. You should just keep moving it. And at the same time, you just need to keep scoring over the avascular area.
So you can see the angel hair fiber here, the nerve plexus, the right nerve going here. Here, as we saw, the morphology looks like of a fiber. There is not a single nerve which is dividing, multiple fibers we can see. Right here you can see the wishbone pattern, where it is dividing into the right and the left.
So now we have just made what happens, we just tend to put a umbilical cotton tape and we just keep it, so it's very useful for traction. So the entire idea of dissection, pelvic dissection, is the bowel should be out of the pelvis. The bowel should be out of the pelvis. If the bowel is there in the pelvis, it makes it more difficult. With the help of needle holder, we hold it. Again, dissections is predominantly, it will be like, first initial dissection is going to go all out posterior, as deep as possible posterior. You can just see all the nerve, right side, left side, the plexus, the hypogastric nerves, everything. You can just see it completely avascular plane. You can just see it. Again, you see the dynamic traction. As you keep giving the traction, you need to keep scoring it. It should not be a static traction, the bipolar one. You just keep scoring it. It's a completely an avascular plane. Make use of it. The angel fibers are there. You just see once the hypoglossal plus the small plexus are there. As much as possible, preserve. You need to preserve all the plexus also.
So the nerve fibers in the lateral wall are very, very close to the mesorectum. So
yeah. See, another thing is we're just going posterior. Another most important thing is, see, as we go posterior, here we have always got a air seal. As the air seal makes it very comfortable. So you know that when the low rectal tumors, then the reaction will be very high. Post-RT changes, reactions will be very high. There will be a lot of edema oozing out. And there will be, once those areas, there will be a lot of smoke also coming out. So air seal makes it comfortable. And in case if you're not having an air seal, always ask your assistant to have the suction near the camera. Just around the camera, ask your assistant to have it. And another important tip is you can just reduce the current and then you also go very slowly. So this thing is complete posterior, as much as possible posterior. Then this is the post-hysterectomized patient, so a little bit changes. And then you go right anterior lateral. This is the right anterior lateral, as much possible as down. Then you go left anterior lateral. high right anterior lateral, then high left anterior lateral as much as possible. Then again you go deep pelvis, then you go low left anterior lateral, then low right anterior lateral. So these are the 5 steps in pelvic dissection.
So I hope you are able to observe the nerve in the lateral wall, which is being preserved.
The post-hysterectomized patient, so a little bit that it will be stuck there to the wall. Again, you can dissect it comfortably. So another thing is sometimes what we do if it's stuck, you can also use a sizer. So you can use a sizer to identify which is the wall. It makes it comfortable. Or you can just pack a gauze also. You can ask your colleague to do a PV. We usually use a sizer for that.
So you can see here at the anterior dissection for both the male and the female patients, the neurovascular bundle of Walsh will be seen at the 10 o'clock and the 2 o'clock position. So if you carefully observe, you can see the nerve fibers going there. You can see the ureter there entering. In the female patient, the nerve bundle will be present below the area where the ureter crosses the uterine. The nerve fibers are being preserved here. As you can see, they are being peeled off like one onion, how we do it. So in our series, we've not had a single patient who had a long-term catheterization. For 2 patients, there was Foley's requirement for about 2 weeks.
This is the sizer. This is the sizer, the McCartney. This is useful for post-hysterectomized patients to put a sizer. So it makes it comfortable to identify and dissect the vault area. You can just see the sizer there. Then we are just going deep right side, deep pelvis. That's the vagina on top. Vagina is being dissected, it's being pushed down completely. The rectum is being pushed down, the vagina. And again, left upper lateral. Again, going back to posterior. So once you go to posterior, say what we need to do is, if you're going to go to a deep posterior, always you need to do a camera 30-degree up. So once you go to a deep posterior, the camera should be 30-degree up. Yeah.
So here we are cutting the Walder's fascia, that is the rectosacral fascia. Now it always in low rectum, it always gives you that extra length.
So the same step, if you're going to do with the camera 30-degree down, it makes it quite difficult. Again, once you do it up, you can just see the difference. It's just completely, it's a different plane and you can just see it. So otherwise, if you're going to keep doing it to the camera 30 down, all the instruments will keep clashing. You will not get the planes and you'll be going in the wrong plane. So this is a 30-degree up, which we are going. So we have just seen the levators. You can just see the levators. Because of the post RT, you will get a lot of edema. Edema fluid oozes out that you need to keep sucking it out. So you go more posterior. This is again the posterior ligament which you are cutting. so that you get the extra length of the rectum. Again, is anterior, it's thinning out. You can just see that posteriorly also, after a point of time, the mesorectum finishes. That's all. So you can see, we have it's only a scissors where the mesorectum is getting over. Then you thin out the mesorectum. There's no vessels there. You just thin out the mesorectum. There'll be no bleeding there. You just thin it out completely. Yeah, it completely gets thinned out. So this is one of the advantages of doing a total TME. So usually for the partial TME, whenever you do for a upper rectal growth, that has got its own challenges. The partial TME has got its own challenge. The chance of bleeding is there and things like that. Again, you need either a vessel sealer or you need some kind of a sealing device. If you notice, so far we have not used any sealing device at all for the posterior dissection, because we are doing a total TME, so it makes it comfortable. You can just see how beautifully it was. The vagina was stuck, how beautifully we could dissect it. And after dissection, it has been completely free. So you need to dissect the vagina well, because or else you will end up stapling the vagina along with the thing. You might end up stapling the vagina. Another important thing is you're looking at your colleague is doing the PR, just seeing whether the margins are okay. So approximately once the total mesorectal excision is done, then most probably your margins will be fine. This particular patient had a 4 centimeter from the anal verge. Again, we just do a PR, we just identify it, and then you can go and staple it. Again, we wanted just another half centimeter, 1 centimeter we wanted. Another important thing which I want to tell you is, initially we put the umbilical cotton tape. That umbilical cotton tape, you need to keep readjusting as the traction keeps going down. So you need to keep pushing the umbilical cotton tape downwards. Only then you'll get a better traction. You just push it down, get a good margin, and push out the vagina. And then here, what happens? We just remove that one port. We just change it to a 12 mm port. We just change it to a 12 mm port for stapling. And then we get a Surefirm stapler 60. Sometimes for males, I use a 45. And I always make sure I always use a 12 to 6 anastomosis, 12 to 6. There's a little big rectum, so we have to use 2 firings. Otherwise, sometimes with just a single firing, it just gets stapled. You can just see the Surefirm stapler. This angle, you will never get it in any other stapling devices. So this is one of the beautiful things for when you're doing ultra-low anterior resection. Definitely, you need to use a Surefirm stapler because the stapling is perfect. The lines are perfect. You can just see 2 staples. There's no overlapping. The lines are perfect, and you get a good margin. You can just go the extra length down because of the angles. And always remember, in males, use a 45. In females, you can use a 60. And the distal end has been stapled. And now you can just see the initial the staple, this thing is there, the pedicle which is there, which you can just see. And then you just score it over whichever the length, the margin, you score it over. The specimen should come out like a tail. You get all the nodes in the pedicle, along the pedicle. From where you have ligated, you get everything. Then you fix up with the margin, the proximal margin. Make sure the tip-up holds that. You should never keep changing. Make sure tip-up holds that. If you notice, in one hand, I've taken the vessel sealer. In another hand, I've got the bipolar. So the bipolar, I can give a traction. With the vessel sealer, I can just, over the scored area, I can just keep going up. It's a very simple procedure. Already the tip-up is holding the proximal wherever you want to transect it. The proximal margin is being held. You just don't keep changing it. Then you keep going with the vessel sealer. You just keep going with you can just see the specimen like a tail. You just go up. We don't use any hybrid model. So once the proximal margin with a good margin is there, then you've got a good margin. Then you make sure wherever you're going to transect, you just make that area very clear of all the appendices epiploiae. Yeah. Then again, you just clear that all the appendices epiploiae, you need to clear it up. Now you just give the ICG. You can just see the flush. The small bowel is being flushed or large bowel is also being flushed. You can just see the difference between the vascularized segment and the avascularized segment. And you can just fire it with 160. You can just fire it with a 60.
So while doing intracorporeal anastomosis, sometimes they do not fire the stapler. They just cut open the specimen and introduce the anvil. But we prefer to staple it for two reasons. We can decrease the chances of contamination. And oncologically, maybe it's safer to staple off the tumor so that, the tumor cells are not exposed.
Yeah.
So here we can see the complete anatomy, the well-preserved fascia over the nerves.
Okay. And next thing is, we do a specimen extraction. We just need to check whether it's coming. It will come out very well because we always do you can just see it's very floppy because always the entire splenic flexure mobilization is done. Once you do entire splenic flexure mobilization is done, nothing to worry about. Then we introduce the anvil via the 12 mm port. We always see if there's a stitch will be there to make sure that it does not slip off. Again, the proximal end which is cut, which has been transected, we open it again. We have a good bowel prep. Bowel prep, we always give it around 36 hours before. And then you put the anvil. Then we get it out in the side. We always try do a end to side anastomosis. We get it. And then we clear it. Again, we just staple the distal cut open end. And then remove the white component of it. And then we get a staple from below. And then we check the lie. Once we always do it. We always check the lie so there's no twist in the thing. And then we get it anastomosis. Doing an intracorporeal anastomosis, it's absolutely a pleasure to do everything. There's no struggle. The entire thing is done under visualization. It's very comfortable. And then you need to make sure the bladder is away. And you can just guide it. It's far better than what you do it in the open anastomosis. So intracorporeal is, I think it's more comfortable. The recovery is faster. And the chances of twisting and error is less. Next thing is we are just like making sure that we pick up the loop of the ileum. We pick it up around 20-25 centimeters from the IC junction. We put two clips, one for the double clip for the distal and one clip for the proximal. This particular patient, one ovary was left behind. That also we have staple. Then we just bag the specimen. And the entire specimen is taken out via the stoma site for this particular patient. It comes out easily. Stoma site. And that we use it for doing a ileostomy. Sometimes what happens, we also extract the specimen via the vagina. We make a cut in the posterior part of the vagina, and then we extract the specimen out after bagging and things like that. So this is about the intracorporeal anastomosis. So all these patients, the same day we make the patient walk, the same way we start orals, and all the patients get discharged the very next day evening. So they are comfortable. This particular patient was BMI was high. She was very obese. She had a few comorbidities. The next day, very next day, she gets discharged. It's comfortable. There's absolutely no blood loss, which you could have seen. And this is our experience of doing a ultra-low anterior resection with intracorporeal anastomosis. This is our technique. And any questions, we are ready to take it up. In all the patients.
So no questions are there online.
Okay. So I'll just touch upon few things. And again, okay, another thing is I just want to tell you is robotic, there are two things. One is this, we do an intracorporeal anastomosis and extract the specimen via the vagina or via the stoma side. Another things you need to understand is there are some people use it a lower midline incision to do. And other people use a fan and steel. So either the best will be to do a natural orifice specimen extraction with intracorporeal anastomosis. The second will be to do the fan and steel incision. The last will be to do a lower midline incision, because the outcomes are totally different. If you do a natural orifice, the outcomes is you can see it very visibly. We have tried all three, but now we have stick on to only the natural orifice. The outcomes are very, very good. So that's one important way of doing. So whatever procedure we have demonstrated, whatever procedure we do is not a hybrid procedure. It's not a robotic assisted procedure. It's a completely robotic procedure. The entire thing is completely a robotic surgery from starting to finish. And we use all the instruments. So only if you make use of all the instruments, the outcomes are also better. And it comes out well. And ultimately, it all depends upon, and it's not about the discharge, it also depends upon the quality of the life and how early the patient is able to get back to normalcy. So intracorporeal makes a lot of difference to getting back to normalcy. Thank you. This is our team. So always I believe the teamwork is extremely important. All the members of the team equally contribute to the outcomes of the procedure, and we are very, very happy to do it, and we do all other robotic procedures. So I'm very happy with my team. Without the team, nothing can be done. Thank you. Any questions?
There are a couple of questions now, sir.
Yes, please.
Dr. Shankar asking, LARS in your experience. LARS, L-A-R-S.
Low anterior resection syndrome.
See, most of the patients have got, whenever we do an ultra low, we always tell them, we prime them before that about LARS. We tell them that this component is going to be there, and we start the patient on Kegel's maneuver before, and then we tell them again. We also tell them that as time goes by, it will improve. So this, we always prime the patient. Counseling the patient for this is very, very important.
So does the port position in XI is same as in Da Vinci X? No. So SI and X are similar port placement. In XI, it is usually in a straight line. So the port position will change in Da Vinci X. Your opinion on
Single staple anastomosis. How do you do? See, Dr. Shankar, I'm not single staple anastomosis. You mean to say this firing just one staple distally and proximally? No. See,
So, Dr. Shankar, single staple anastomosis, what do you mean by that?
Because, okay, going on to the next question, how do you do a gut preparation? So again, I think we do it a very conventional way. We do the bowel preparation 36 hours before. We give a colo prep, and the most important thing, why we do it quite early, and after that we just keep the patient on clear liquids or liquids. The most important thing, why we do it a little bit 36 hours before, is because we have found that a lot of edema is there. Just the previous day evening, we do a lot of small bowel edema is there. that makes the small bowel keeps falling. So that's the only reason why we do it around 36 hours. We have made it a protocol, and that has helped us. Initially, we were doing it just the previous day evening, but now we have started doing it at least 36 hours before. That has helped us a lot because it prevents the small bowel edema and prevents it from falling.
So we both do both the mechanical bowel preparation and we start antibiotics 5 days before. And as sir said, 36 hours before we give the colo prep, and after that the patient is on clear liquids. And also on table we give a rectal wash. So we give a good rectal wash on table.
See, another thing, another tips is, what we do is, what Priya said is very important. We give a rectal wash. We make sure that the last motion, even if the patient is passing a motion at previous night 10 o'clock, or the patient has passed the motion the day of surgery, early morning of surgery, we make it as a routine. It might find a little funny, but we ask the patient to take a photo of the last motion and send it to our team. So because one of our registrars or someone sees it, so we make sure that it is very watery. Sometimes what happens, the patients do not take the preparation as told. Sometimes they vomit off and then the preparation is not adequate. There have been instances where when we see that during the photo that the bowel is not prepared well. The last thing, we have even cancelled it. And sometimes once we give a bowel wash, we feel the motion is it's not well prepared. We have cancelled it. Trust me, the cancelling is far better. Transanal transection with single staple anastomosis.
So that we do for a colo-anal anastomosis. So when we do a very ultra low intersphincteric dissection, that we do in a colo-anal anastomosis where the anvil is placed proximally and we fire the circular stapler from outside.
Thank you, sir, for answering all the questions. I don't see any more new questions over there.
Yep.
Yeah. Thank you, sir. Thank you for a wonderful session, sir. Thank you, ma'am.
Thank you.
Thank you.
Thank you all, and I hope it was there was some enlightenment. And thanks a lot. You can feel free to reach out to us. Thank you so much.